Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for the dermatology section of this series. Today, we're diving into perioral dermatitis, a condition often misdiagnosed and misunderstood, but one you'll likely encounter in clinical practice. If you're preparing for the PANCE or managing patients in the clinic, this episode will provide you with the essentials. Let's get started. Let's begin with the basics. Perioral dermatitis is a chronic inflammatory condition of the facial skin, often considered a variant of rosacea. While the exact cause isn't well understood, a key trigger to remember is topical corticosteroid use, which can worsen or even induce this condition. An important pearl is that patients may develop this condition after use of topical corticosteroids, thinking they're treating another skin issue. So if your patient's story includes steroids, your radar should be up for perioral dermatitis. In addition to topical corticosteroids, several other factors have been proposed as potential contributors to perioral dermatitis, including fluoridated toothpaste, skin moisturizers and cosmetic products, fusobacteria, Candida albicans, hormonal fluctuations in women, and oral contraceptive therapy. Now, who's most at risk? Perioral dermatitis predominantly affects women aged 16 to 45, although it can occur in children and older adults as well. Here's how it typically looks. Patients often present with small erythematous papulopustules that appear irregularly grouped and symmetric on an erythematous background. It's called perioral for a reason. It starts around the mouth, but spares a rim around the vermilion border of the lips. It can also affect the nasolabial folds, chin, and even the periorbital area in some cases. How about symptoms? Patients might feel some burning, itching, or tightness, but more often they're concerned about the cosmetic appearance. Something important to remember is that unlike acne, there are no comedones in perioral dermatitis. In most cases, the diagnosis is clinical, but there are times when you might need additional testing, such as when you suspect Staphylococcus aureus. In those cases, you can consider a bacterial culture to rule out the secondary infection. You definitely want to keep your differential broad early on. Conditions like rosacea, seborrheic dermatitis, or allergic contact dermatitis can present very similarly. All right, so how do we treat this? Let's start with a crucial don't. You want to avoid topical steroids. Using them can exacerbate the condition or even induce steroid acne. For mild cases, topical treatments are your go-to. So this would be either metronidazole gel or erythromycin or clindamycin gel. For moderate to severe cases, or when a case is refractory to topical agents, systemic therapy is key. This would be with a tetracycline like doxycycline or minocycline. But just note a quick caution. Remind patients about the photosensitizing effects of doxycycline. Prevention plays a big role, especially for recurrent cases. You want to educate patients to avoid topical corticosteroids and irritating skin products. Recommend gentle, non-comedogenic cleansers and moisturizers. As far as complications to watch for, it's important to note that if untreated or poorly managed, perioral dermatitis can persist for months and may lead to post-inflammatory changes such as hyperpigmentation. Patients can also become frustrated, especially if they're misdiagnosed and prescribed steroids, which worsen the problem. A clinical pearl is to always ask about steroid use when taking the history of a facial rash. It's a game changer for diagnosis. Lastly, let's wrap up with a couple of questions to test your knowledge. Question 1. A 30-year-old woman presents with a localized perioral rash. Physical exam reveals grouped erythematous papulopustules around her mouth. sparing the vermilion border. She has been using a topical steroid for a rash diagnosed as eczema. What is the next best step in management? Is it A, continue topical steroids, B, stop steroids and start topical metronidazole, C, prescribe oral doxycycline, or D, perform a bacterial culture? I'll give you a second. If you chose B, stop steroids and start topical metronidazole, you are correct. Discontinuing steroids is crucial, and topical metronidazole is one of the first-line treatments for a mild case such as this one. Question 2. A 35-year-old woman with perioral dermatitis has been using topical metronidazole for 4 weeks with minimal improvement. What is the next best step in management? Is it A, switch to topical clindamycin, B, add oral doxycycline, C, increase the strength of topical metronidazole, or D, perform a bacterial culture? If you chose B, add oral doxycycline, you are correct. For refractory or moderate to severe perioral dermatitis, systemic antibiotics like doxycycline or minocycline are the recommended options. Great job today. Thank you for tuning into the Pro PA podcast. Don't forget to hit subscribe and turn on notifications so you never miss an episode. Look out for future episodes in our dermatology series, where we'll continue tackling high-yield topics to help you prepare for the PANCE and succeed in clinical practice. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you next time.